Good evening. Coming to the last abstract in the current session. So now I will discuss the role of local radiation therapy in a different set of patients who are the EGFR-mutated patients. So this was published in the Thoracic Oncology. So for mutation positive patients, the TKI are the standard of care. The first generation TKI has shown a median PFS of around 9 to 13 months, while the third generation newer TKIs have shown a median PFS of 11 to 18 months. The local intrathoracic progression still remains a challenge. Approximately around 2/3 of patients will have a local intrathoracic progression. The role of local consolidation RT in this setting remains controversial, and still there is no clear guidelines whether to add a local therapy or not. So aim of this multicentric randomized phase 3 trial was to evaluate the efficacy and the safety of EGFR TKI with concurrent thoracic RT for patients of EGFR mutation, oligo-organ metastatic NSCLC. So in this trial they had a pre-planned interim analysis, which were yearly interim analysis for 4 were planned. After first 2 analysis, the accrual was stopped due to significant results, and the final analysis was presented with a follow-up till February 2023. So they included the histologically proven NSCLC with age of 18 to 80 years, ECOG score of 0 to 1, EGFR-19 deletion or L858R mutation positive. No synchronous metastatic organ should be 1 to 3. A number of 2 cycles of chemotherapy were permitted prior to the randomization, and life expectancy defined by the physician was of more than 3 months. So they used the first generation TKI ecotinib, 125 mg per hour thrice a day. The thoracic RT was planned to start within 14 days of starting the TKI. They had planned a conventional fractionated RT 60 degree in 30 fraction over a period of 6 weeks with either a 3D CRT or IMRT as per physician choice. They had used the standard dose constraint from the lung, esophagus and the heart. They included the primary lung tumor and the involved nodal area for radiation. The radiation to the metastatic site was as per the physician's choice. The primary endpoint of the trial was PFS. The secondary endpoints were OS and the adverse reactions. They had exploratory endpoints like local regional free PFS and the distant metastasis PFS. So 1:1 randomized. The planned accrual was 342 patients. So between April 2016 and March 22, they had randomized 118 patients between the TKI and the TRT arm. So they had done both intention to treat analysis as well as a per protocol analysis also. These are the baseline characteristics. So it was equally matched between the 2 arms. Almost 50% of the patient had the brain metastasis also, and the radiation to the metastatic site was given in around 45% of the patient in both the arms. Coming to the adverse events, so grade 3 or 4 adverse events were more in the thoracic radiation arm, 11.9% versus 5.9%. The esophagitis was commonest, 6.8%, followed by the pneumonitis, 5.1%. The patient in the TKI group also had esophagitis or pneumonitis because of the treatment to the metastatic sites as per the physician's choice. So at the median follow-up of 27 months, in the intention to treat analysis, the PFS and the OS were significantly better in the thoracic radiation arm. Similar results were seen in the per protocol analysis also. Coming to the patterns of the first failure, in the TKI arm, the loco-regional relapse was seen in around 33% versus 13% in the thoracic arm. The distant metastasis was seen in 37% of the patient in the TKI arm versus 50% in the thoracic arm. Thoracic radiation arm also had a better loco-regional free PFS, but similar distant metastasis and the brain metastasis PFS. So the authors conclude that the survival benefits seen with the thoracic arm was mainly attributed to the better local control in the intrathoracic primary as well as the nodal control. In the exploratory subgroup analysis, the thoracic RT arm had a more benefit in the female patients, older patients, and the patients who didn't receive any induction chemotherapy. The hazard ratio for the PFS was similar in the different metastatic organ groups, 1 versus 2 versus 3, as well as the metastatic site groups also. So coming to the last slide, the strength of present analysis is they had a uniform RT protocols with a stringent dose constraints. It represents the population in the general populations also. The brain metastasis patients were included in the trials. The limitation is they used the first generation TKI as the standard arm. The small number of patients because of the early completion of the trial, and they use the protracted fractionation like a 30 fractions for a 6 weeks treatment. Thank you.